what we're going to have is a three-part conversation this morning. The first with Dr. Sens and Dr. Gogia talking about an article in the New York Times and a chatbot tool, which we'll all get to share. Next, Dr. Roberts talking about her works with in Sacramento in disparate populations, folks who don't have access, and pop-up vaccine clinics. And last, a panel where we surveyed the physician enterprise providers, got back, I think, John, 100 responses or so, and we'll have a conversation about what those responses said. So just by way of introductions, Dr. Ashley Sens is a pediatrician by training. She received her medical degree from the University of Iowa College of Medicine and completed her pediatric residency at the Dartmouth Medical School. Dr. Sens currently is the Chief Medical Officer at the Woodland Clinic Medical Group in Woodland and has been a key contributor on numerous committees in the physician enterprise. I always am happy to call Dr. Sens, and she's always happy to say yes. So we're very happy to have her on our team. Dr. Namrita Gogia is an internist and primary care physician at Mercy Medical Group in Sacramento. She received her medical degree as did Dr. McGinn at Creighton University Medical School and completed her medicine residency at UC Irvine Medical Center. She is the director of the Vaccine Task Force and Ambulatory Vaccine Rollout for Dignity Health's 6 Sacramento area hospitals and the Vice Chair of Internal Medicine for Mercy Medical Group. Karen, I already introduced, and I hope she gets a chance to tell her story about collection of that swab. Dr. Bianca Roberts is a family physician at Mercy Medical Group in Sacramento. She received her medical degree from UC San Francisco School of Medicine and completed a family practice residency at Sutter Health in Sacramento. She's currently the chair of the Department of Family Medicine. She's on the Mercy Medical Group Board of Directors. She is a member of the Mercy Medical Group Vaccine Task Force, and we'll hear from her this morning about her latest work as a medical director of the Greater Sacramento area equity vaccine pop-up clinics. So I think we have a great morning ahead of us. And so first, Dr. Sens and Dr. Gogia, I'm going to turn this over to you. And I would say for our audience that this is going to require some audience participation. John is going to instruct you how to vote when the time is right.
Yeah.
Okay.
All right, so I'm going to go ahead and get started. So first of all, if you're interested and want to do more of this feature, there's a great article in the New York Times titled, "Your Friend Doesn't Want the Vaccine. What do you say?" And you can, interchange that with friend, neighbor, colleague, patient. So these are great. This is a great toolkit that they developed for not just, the general public, but also even us as physicians that we can use. And they use the principles of motivational interviewing, and they backed it with research from psychologists and experienced providers on how to encourage individuals to, for example, get a vaccine. So we thought that it would be great if we could do a poll and just kind of get started and get some ideas on what you think the right response would be. So with that, I don't know if we want to pop up the first poll question. Perfect. So the first question is, if you have a friend or a patient, let's say it's a friend, and they say, well, the vaccine just might not be safe. What are your thoughts? So the answer could be, how would you respond to this? Would you say, A, the science is pretty clear, the vaccine is safer than COVID? B, okay, so you're conflicted. You want to be safe from COVID, but you're worried about the shot and want reassurance? Or would you say C, don't believe everything you read on Facebook. I'll send you some reliable articles. So we're going to give you a minute here to select your response, A, B, or C. All right. And hopefully everybody has selected your response, and then we can go on to the next question. All right, so Is everybody at number 2? I hope so. So we're going to go on to the next question, which is, let's say that your friend says, well, the vaccine seemed so rushed. Maybe they didn't test it enough. How do we know they didn't cut corners? Would your response be A, I was worried about that too. Can I share some stuff that made me feel better? Or would you say B, we can trust researchers and doctors. They know what they're doing. Or would you say C, they've been working on a version of this vaccine since the SARS outbreak in 2003. So we will give everybody a second to select their answer. And then the third question is, what if your friend still responded back and said, well, you know what, maybe the vaccine is more dangerous than getting COVID. Since I'm young and healthy anyways, maybe I don't need the vaccine. Would you say A, yeah, I wondered about healthy people too, and it turns out we're more likely to be struck by lightning than have a bad reaction to the shot. Does that help? Or would you say, nah, you're 3 times as likely to be struck by lightning as to have a deadly reaction to the shot, but COVID is deadly? Or would it be option C? No, besides, it's not just about you. If you care about others, you'll get the shot to protect them. So we'll give you a second to respond to that.
Oh, I see.
And we'll get the poll results and we can talk about each of those questions. And we'll start with the first one, which was the safety one.
Okay. Wow. Great.
All right. I think we did pretty good here. So I'm going to turn it over to Dr. Sens and we'll go into each of these questions in depth.
Excellent. Thank you, Dr. Gogia. This chat box is really quite helpful. And as Dr. Gogia suggested, I recommend that you actually go to the article and spend some time going through the entire conversation. This is just a portion of it. So the first question, or the first response from the friend is that the vaccine might not be safe. What are your thoughts? And the best answer here is to acknowledge that the person is conflicted. So most people that we're going to encounter are not 100% anti-vax. Those are a small part of our community. Most people have some degree of fear or uncertainty, but there's a part of them that wants to get vaccinated. And so kind of honing in on that and recognizing, reflecting that back to them can be very, very helpful. And especially doing that first, rather than just jumping to a blanket statement about the fact that it's safe, is more effective.
Yeah, I would say definitely echoing their concerns and just kind of seeing where they're at in terms of their ability to accept the vaccine is the first engagement that you want to really do with the patient or the friend. All right, so then the second question was, the vaccine seemed so rushed. Maybe they didn't test it enough, How do we know they didn't cut corners?
Yes, so in this situation, the best response here is to reflect back their concern with them and actually acknowledge that there is some legitimacy to the way that they feel. So saying, I was worried about that too, is a good way to do that. One of the things that I have learned from my experience of working as a pediatrician in a community with a higher than average vaccine hesitant population is that being dismissive of concerns is never really effective. And so it's easy for us as clinicians to kind of quickly get to that point of just wanting to dismiss it by saying that's not true or the evidence doesn't support that. But taking a moment to really acknowledge the concern and fear that the person has, to establish that rapport and establish that trust so that the person feels that they're being heard and seen and respected is much more effective. And so just taking that moment to reflect back their concern before you start unpacking the actual concern that they have. And then also within that, when you do kind of reflect back that concern to them, you can ask them more specifically what their worries are. And I have found that to be very, very important, because sometimes we assume that we know what's really underlying their concern. When we ask them, it turns out that there's really something else that they're worried about. And you want to be able to address that concern specifically for the person you're talking to.
Yeah. I would agree with that. It's so emotional for the patients. It's not necessarily the facts or, you know, the true safety data that they're really worried about. They want comfort and acknowledgement. All right. And then the third question was about the, you know, if I'm young and healthy and I don't think COVID is going to affect me, then why do I really need this vaccine? And it's something that I'm encountering more and more in my young patients in the clinic, that we're at this point in the United States where things are opening up, you know, people are feeling pretty good. Why should I even bother getting the vaccine now? And so it looks like we saw a lot of you answered correctly here, which is, yeah, I wondered about healthy people too. And it turns out we're more likely to be struck by lightning than have a bad reaction to the shot. Does that help?
Yeah, so thank you, Dr. Gogia. So this, again, the person starts off by saying, I wondered about healthy people too. So creating that alliance, right? Saying, you know, your concern is, you know, you're communicating to them that their concern's not unfounded. You're not just dismissing it. So creating that alliance is really, really crucial. And then trying to put the risk in perspective with a well-known kind of example can also be very effective. I want to just quickly point out the last answer, which 32% of the people selected. I think it's worth kind of looking at that particular answer because it's very tempting to jump to that. And it's not that talking about protecting others is never appropriate. I think there may be conversations where you can kind of weave in the idea of responsibility and public health. But I think in reality, a lot of the people that are concerned, and I'm going to speak a little bit now as a pediatrician, particularly since Pfizer has now come down to the age of 12, a lot of parents have are not going to be quite as receptive to the idea of choosing public health as the motivation if they feel that choice increases risk to their child, right? So if I'm going to have to make a decision to vaccinate my child and I'm going to accept some risk because it's for the greater good, at least in our culture today, that tends to be a bit of a high hurdle for some parents. And so that's one reason why I would sort of avoid this as the third answer as your kind of go-to, and think more about what the absolute risk is. And having a conversation about risk reduction, talking about the fact that the vaccine can actually reduce the risk of harm to the child, will tend to be more effective than talking about the public good. Not that that's not important, but again, if we're trying to get people who are kind of hovering around no to yes, that can be more effective.
All right, great. And as both Namrita and Ashley said, there's more to the article and there are more questions. I would just make one comment, and that is, as I think we heard the panelists say, this is really about trust and relationship more than about blasting people with just get the vaccine. And there is sort of this leadership concept of balancing advocacy with inquiry. And in this case, if you look at each answer and the answers that won, they all had question marks after them because they asked the patient a question. How does this work? How does it feel? And they validated the patient's concern. And the losers, not the losers, but they were advocacy statements. Just get the vaccine. There's no computer chips in it. And I think that there is a valuable message there, certainly for vaccine hesitancy and for how we develop relationship and trust with patients in general. So thanks. This is absolutely great. And we've gotten lots of comments that people liked the polling. So we'll do more of that. Now, I do know, Cindy Garrett, did you have a brief question or comment that you wanted to make?
Oh, no, I'm so sorry. Did I raise my hand?
You did, but that's fine. Nice to see you. Good morning.
I didn't mean to.
Okay, very good. So now we're going to move on to Dr. Roberts, who's going to talk to us about some of her spectacular work in Sacramento. And I think we have some slides to bring up for you, Dr. Roberts. And so here we go.
Thank you.
There we go.
I'm really excited to be able to be here to speak today about overcoming vaccine barriers in underserved communities. Next slide, please. When we hear about COVID vaccine disparities, the first thing we often think about is hesitancy in minority communities. Many of us are familiar with the Tuskegee experiment, where between 1932 to 1972, 600 Black men, their wives, and children were deceived into participating in a research study that denied treatment to syphilis so scientists could trace the progress of the disease. Next slide, please. Though the Tuskegee experiment is the most shared example of racism in medicine, it's not an isolated event. Many communities, I'm able to speak specifically to the Black community, are familiar with other authorized medical experiments that were carried out on people of color for the benefit of medicine. If you're interested in learning more, I highly recommend choosing some of these books, particularly Medical Apartheid by Harriet Washington. Next slide. Some may think the historical events in medicine were events of the past, and now our focus should just be on moving past this and restoring trust in the medical community. It is important to note that some of the acts have continued through current times. Some of us may be familiar also with the Mississippi appendectomies, where unnecessary hysterectomies were performed at teaching hospitals in the South on women of color as practice for medical students. A third of sterilizations were done on girls under the age of 18, some even as young as 9. And more recently, California prisons have authorized sterilization of nearly 150 female inmates between 2006 and 2010. And it's reported that doctors performed tubal ligations that former inmates say were done by force. Next slide, please. We may think mistrust in medicine only applies to adults, and our pediatric population should not have hesitancy. But even in the 1990s, experiments took place on Black and Hispanic children where they were given cardiotoxic drug fenfluramine at New York State Psychiatric Institute in an effort to test a theory that violent or criminal behavior may be predicted by certain levels of brain chemicals. Next slide. Many communities that have mistrust in medicine are often hardest hit by COVID, particularly communities of color and communities with lower median income. Next slide. However, when we look at the actual percentage of vaccine distribution, the race rates do not match the rates of the general population. In California, for example, this slide was taken from a little bit earlier. There's been a lot of work that's moving the bar a little bit, but about a month ago, the Black population has only received 3.2% of the vaccine, but are 10% of California's population. Next slide. When we look at vulnerable communities that are in the lowest health quartiles in California, these communities have also received the lowest percent of actual vaccine. Next slide. Surveys performed by the Kaiser Family Foundation to gauge vaccine interest in the general population have shown an increase in vaccine interest over time. So the percentage of US Black adults who say they have either received a vaccine or want to receive it as soon as possible rose from 41% in February to 55% in March. This compared to an overall rate of 55% American adults reporting to be vaccinated or wanting to be vaccinated or in February versus 61% in March. So the interest gap between Black community and Americans is not large. And also overall, many Americans are interested in getting the vaccine. Next slide. To reach the patients who desire vaccination, we must overcome vaccine barriers. So at this time, I want to walk through some of the barriers that exist and give examples of the work that's been done in Sacramento to overcome them. Next slide. Oh, go ahead and yes, thank you. So first, vaccine access relies heavily on online registration. So many of these vaccine clinics fill up quickly before patients in vulnerable communities have the opportunity to register. Barriers include the need to have email access, adequate internet access, work flexibility, and digital literacy. So really to overcome this, there's got to be multiple mediums for vaccine registration, in-person, telephone, apps, just have to be multiple mediums. Next slide. Next slide, please. Okay, here we go. It's already been shown in studies that in communities with the highest risk of infection, Local community health workers have demonstrated their expertise in getting more people tested and connecting them with the care that they need. The same trusted workforce can be mobilized to address current vaccine uptake disparities. So it's really important for us to partner with our community-based organizations. For example, medical groups and vaccine distributors can work with community organizations to provide a secure vaccine telephone line so that patients can call and get registered for a vaccine clinic. At Mercy Medical Group, we did arrange this with NAACP, as well as several other community organizations. We've been able to provide ongoing telephone registration for our vaccine clinics and then open up the regular online registration to the rest of the community as the date nears. It is crucial for medical professionals to lead community-based vaccine discussions. I was able to lead a town hall discussion with NAACP in Sacramento, as well as several other talks with the Black churches in Sacramento and also the Bay Area. Other medical groups have done similar community events to provide information in that trusted space. Dignity Health also did a lot of great work in partnering with several community-based organizations to put up pop-up clinics within vulnerable communities. This was one of the clinics that I had the opportunity to participate in. It was done at the Urban League, and the community helped provide the staff and the workers, and it was well received by the community. The Sacramento County also partnered with several community-based organizations to put on weekly vaccine clinics in a vulnerable community in Sacramento. Thousands of patients continue to get vaccinated there each week. It's important that vaccine clinics actually exist within the boundaries of those vulnerable communities. It's really not practical for us to expect vulnerable patients to travel by public transport. Had it not been for the advocacy of Council Member Mai Vang of South Sacramento, the patients in these multi-generational homes in the area of Sacramento that has the highest cases of COVID would not have been vaccinated. It's been a very successful effort. And it's super important for us to provide vaccine resources and communication in multiple languages. However, it's really difficult to find even consent forms written in multiple languages. So here's an example of what's being done in some of those community clinics. They've translated forms in multiple languages, not just Spanish and English, but we have multiple languages in our country. It's important for us to provide walk-up access and family access. So some of these community-based clinics really, they leave room to allow for when family members come in with the registered patient, they can just add them onto the schedule. Or if someone in the community is just walking down the street, they can just pop in and get that vaccine too. For us in our practice, patients come to us because they do trust us. And some of the feedback that I got back from a lot of the community organizations is that when they go talk to their doctor, it just seems like the doctor doesn't have a lot of information about the actual vaccine. So we have to become that informed source. We have to know how exactly it works, what's actually in the vaccine, and were there people of color in the trial, and did people of color also participate in the development of the vaccine? And we need to be honest about the potential side effects and share those with the patients. So in summary, we should become informed about historical and current events that have led to distrust in medicine. It's important for us to learn about social determinants of health and become intentional about overcoming barriers in registration, communication, and location. We should become informed about the vaccine trials and the actual contents of the vaccine. We have to be open and honest about side effects and become true partners with our community organizations. Addressing disparities in vaccine uptake, it requires a multi-pronged approach centered on the needs of historically marginalized communities. So to bring about change, you must not be afraid to take the first step. We will fail when we fail to try. Thank you.
Thank you. Absolutely great. It feels it's about going to the people, not making the people come to us in multiple dimensions. Absolutely great. Thank you so much. So we're going to have our panelists, and Dr. McGinn, I think, is going to join us for that. He's been on a PTO day, but here he is, and so happy to have you, Tom. And we put together a series of questions for medical staff leaders across the country and sent it out. I think we've gotten back over 100 responses, and they're basically these. So we just thought we'd have the group spend about 10 minutes talking about these questions. And I think what we've heard in the last 20 minutes kind of helps center us on that work. And at the end, before we close, Karen, I'm going to ask you to tell your story, so don't let me forget. So the first question is, for patients on the fence about getting the vaccine, but then decide, for patients on the fence about getting the vaccine, but then decided to get a vaccine, what messages and approaches have been effective to shift their mindset? So they were on the fence, then they decided. What happened? How did they do it? Any comments?
I can go ahead and start. I really think that it comes down to just connecting with their patient, and really just, I had a patient yesterday, for example, who, he's been drinking a lot. He had gallbladder surgery, and now, he's finally over his surgery. And I said, oh, well, did you get the vaccine? No, I've been waiting to recover more. I'm like, it's been 2 months since your surgery. What are you waiting for? So, I told him, like, your liver is not great. You have other comorbidities, and I really think it's important for you to get the shot. And, my cousin just passed away from COVID. His family is devastated. I really want you to get it. And I think just having that connection and also sharing a personal story about either a patient or a family member, just connecting with a patient is powerful. And I think that can really, really make a difference. So I would say really connecting with the patient.
And I thank you for that, Dr. Gogia. I just want to reflect back to you that when I heard you talking and kind of reliving that conversation, I sensed the empathy and the concern that you had for that person. And I really sensed that when you talked with that patient, that your patient felt that you cared about him. And I think that's really, really critical, that it's not about trying to win an argument, right? It's not about trying to, I'm right, you're wrong, but it's, I care about you. And this is going to protect you. And I just want to point that out, because even in that brief little, description, it came across really strongly.
Yeah, thank you. And I think, just really, they want a family member. They don't have that other person that's telling them to go get this shot. That's us. That's us for these patients. And we need to fulfill that role and do the right thing.
Yeah, I do think it was that great combination of your clear sense of empathy for the patient and also your personal story. I think how that in some ways charged you to be more concerned about him. Look, I went through this. I don't want you to have that. And the knee-jerk response to try to challenge them it's hard to fight. It's harder to fight when it's your family too. That's the most difficult. Those are the most difficult ones to hold back.
So in addition to inquiry and advocacy, it's sharing a bit of yourself, and that's what you did. And that honestly sort of breaks down the barrier. It's not the white coat person talking, it's your friend, it's your colleague. I want to tell you what happened to me and why I'm so passionate about it. So great. Any other thoughts, comments, things folks want to add? All right, let's go on to the next question. News about the J&J vaccine may have discouraged some people from getting the vaccine at all. Has there been messaging you've used in your own practice that has been effective in overcoming these concerns?
I can start this one. In the Northwest region, we've had really the luxury of having really good relationships with our pro sports teams, where we have gone out and set up vaccination clinics at T-Mobile Park, at Lumen Field, where our soccer teams play. And I've gone as a vaccine ambassador a lot of days and just stood there and answered questions about vaccines. And the Johnson & Johnson one comes up a lot about, it really breaks down into really two camps. One, the I want the good vaccine. I don't want the Johnson & Johnson or the blood clot risk. And to address the blood clots that came up, I just kind of reiterate that your chance of getting a blood clot from actual COVID-19, whether it be mild, moderate, or severe, is significantly higher than what you would suspect with the vaccines. And the vaccines have been proven to be quite safe in terms of the blood clots. I also reiterate the fact that, you know, part of the reason why they kind of called back the vaccine was to make sure that those of us in healthcare were aware. We wanted to do more digging, get more information, and really it didn't prove to be a much bigger issue than what we thought out of those 6 or 7 cases. And then the other group is the I want the good vaccine. I don't, because people hung on to the 66% efficacy versus the 95% efficacy. And I think in the vaccine rollout, we did a really bad job of the goal of vaccination is not that you maybe won't get the disease, it's that you will not die of the disease. And when you look at all of our vaccines across the board, they're quite good at their intended goal of you not dying of COVID and you not getting out of the hospital with COVID. And that last part is really what's been really effective in just talking to people out in the sports parks, because it's such a wide range of individuals. And the other thing that I realized is that we kind of put people in 2 batches of vaccines, either you're pro-vaccine or you're vaccine hesitant. And what we found is there's a whole bunch of people in the middle that are these vaccine, I call them the vaccine apathetic. They don't really have a strong opinion, but because of it, they don't really want to be inconvenienced to go get it. So whatever you're at in your local market, if you find an opportunity to get vaccines in front of a large group of people, take it. Work with your local, whether it's a high school sports team or a county fair or whatever's going on in your community, see if you can get a pop-up and get people to actually engage and get out there and talk to people. Because what I found and what we found is that if we could actually talk to someone one-on-one, as a professional, as a confident person, we will get you across the line. We have almost 100% close rate at the sports events when we can talk to someone on their personal level. So that's what Dr. Gogia said before, is like, you got to meet them where they're at. And so that's what I found to be really effective.
I think it's interesting that you guys actually had a question answering person, a vaccine ambassador. I think that's a great concept.
It was an accident. I happened to be there to observe.
That's great.
Just kind of, and then we started staffing it as a role, because people don't want to come. As soon as they make eye contact, we can go engage them, and then we get them in line. It's been really effective.
I love that.
Yeah, the
did you have a little booth? You know, did you stand in a little booth with a cardboard thing?
No, I just, as soon as they made eye contact, I closed. And if it means walking down the concourse with them for 5 minutes, talking to them, I've done that. And but again, it's those personal connections, and then they see you and they listen to you, and then you can get them back in line. It also helped that one of our vaccine stations is right next to the beer line, so we had some extra opportunity to talk to them.
I love it.
I'm going to move us on to the next question here, which is, how do you handle patients who use analogies like it's more dangerous to drive the car to the grocery store than dying of COVID? Have you addressed these comments in your practice? And if so, what is most successful?
I have a few comments about this, especially looking in some of the town halls and community discussions. This has come up quite a bit. And I think a lot of our community, they don't really understand what the other long-term effects of COVID are. So I share with them about COVID fatigue and, you know, how the lungs change for many patients, and how there's super healthy people who they're still tired and they had COVID a year ago and they haven't been able to go back to work, and how there's an increased risk of heart disease by 20% if you've had COVID. And those things are really scary to people, just not being able to be themselves. And I do share, you know, we as medical professionals, we can't really predict which patients are going to be the sicker post-COVID versus not. And that's not information that is being shared in the media about the post-COVID syndrome. And we have a lot to learn as a medical community about how to take care of these patients, and they would be the ones that we would be learning on if they were to get COVID. So a lot of patients do think about that, like, well, I didn't know it wasn't just about deaths. I didn't know you could also have long-term effects from COVID. So that actually usually speaks to some people.
Great. Other comments?
I just want to take a moment and address the specific population of the healthy kids, the healthy young kids. I have never, ever been successful in convincing a vaccine concerned or vaccine hesitant parent to get a vaccine by trying to scare them into, being afraid that their child's going to die of meningitis or their child's going to, die of pneumonia. Um, you know, mothers and fathers don't like to think of their children as being at risk of dying of something. And so it's just never been very helpful for me to try to use the scare tactic. So over time, I have found that most of those parents can get to a yes if you talk to them more about this being a risk reduction and increasing safety. So instead of, I'm going to prevent your child from dying of meningitis, meaning shifting a conversation to, I'm going to give you a tool that's going to help protect your child, reduce the risks of harm to your child so that your child can fulfill their full potential in life. It's a much more positive message. And thinking about that in terms of like the car accident, you don't put your baby in a car seat because you're really afraid that you're going to have a car accident or because you think some bad harm is going to come to your baby. You do that because, even though you're optimistic, you do that just to reduce that risk, just take it down as much as you can. And that's what the vaccine does. And for a lot of those parents approaching it from a risk reduction positive message, it just tends to work better than a scare tactic.
All right. We have one more question. Thank you. And I want to point people in the direction of the chat. There's a letter and a tweet from Dr. James McDevitt from the Baylor College of Medicine. And folks might want to jot that down and take a look at it as we close. With the recent expansion to vaccinate kids from 12 to 16s, how would you approach the conversation with the hesitant parents who think children and teenagers are already at low risk to get seriously ill from COVID-19?
I think Dr. Sens answered this one
Yeah.
beautifully. As a parent of a 6-year-old and a 3-year-old, it does come across my mind. I'll be honest. I know that the transmission is low among that age group. I know that they typically do well, but I think that it's really important to how we couch it to patients and how we message it. So, Dr. Sens, if you have anything else to add, because that was really great, but I feel like as a pediatrician, this is, so important.
Yeah, that's it. I was talking to Dr. Greensweig the other day about kind of more public health messaging and campaigns. And when we live in a society that, there's just a lot of privilege in the United States, right? And so, there are a lot of children who, are, their parents are not living on a day-to-day basis worried that they're going to die, which is a wonderful thing. But trying to impart that fear on them is just not going to work. So when you say things like, just like you buy healthy vegetables and fruits and, you take your kids out to play and you're doing all these things to promote health and wellness, a vaccine is a part of that plan. And it just tends to be in my particular population that I serve, I should say, that tends to be a more effective message.
All right, great. There is one question, and we're gonna answer this offline, and it's a question about people concerned about lack of long-term studies, hidden side effects, and also fertility. But I think we'll take that offline, and thank you for that question, and we will answer that. So I want to thank all of the panelists for great presentations, great conversations, and really, I think a multi-approach to vaccine hesitancy for people who are on the fence, not for people who are just, I'm not going there. And I think we've heard a lot of good things about advocacy, inquiry, sharing a bit of yourself, establishing trust, all those things. And so we're going to close.